ovulation trigger in ART only. So that is ART, we specifically mean IUI and IVF. And I want to acknowledge Dr. Nupur and Dr. Smita Jain is here because they have helped me with the slides. Now, ovulation, as ma'am has already described, not an explosive event. There are multiple series of events: resumption of meiosis, maturation of nucleus, maturation of cytoplasm, expansion of tumulus, prostaglandins are produced, proteolysis happens, and finally there's ovulation. So the 48 hours after LH surge, how is it divided? 14 hours is the rise, 14 hours is stable, and 20 hours is the fall of the LH. Now, there are primarily 4 kinds of triggers: HCG, GnRH agonist, kisspeptin, and recombinant LH. FSH, LH, and HCG, if you compare, take a look at the initial half-life. So, LH is 20 minutes versus the 33 hours for the HCG. And LH and HCG also have similarities. That is, they are going to share the, they share about 81% of the amino acid residues in the beta subunit, and alpha is almost the same. But remember, they are not identical sisters. The half-life, and look at the receptor binding affinity for LH versus HCG. So HCG remains for a very long time and it has a very potent binding to the LH receptors. So first, talking practically speaking, how is this applicable to us? First, speaking about IUI cycles. What to give trigger and when? For oral ovulogens, follicle size more than 18, 20 to 22, because of the cytoplasmic maturation takes time. So, and there is no panic, no urgency to rush for trigger. In gonadotropin cycle 16 to 18, and the trigger is with urinary HCG 5000, 10,000, recombinant 250, or if you are using GnRH agonist, something like leuprolide acetate, then 0.5 to 1 milligram. Now, when should you be cautious about your trigger? If you have more than 2 follicles of 16 millimeters, if more than 8 of 12, or estradiol is more than 1500. Why? Because there is a risk of hyperstimulation and multiple pregnancy. If the follicles are more than 2, that is 16 millimeters, or more than 3 intermediate size follicles, this ASRM guideline has suggested that you should cancel the cycle and of course luteal phase support. So what to do in these cases? First of all, you can withhold your trigger, wait for spontaneous rupture, use GnRH analog as trigger. But in that case, the GnRH analog I use is triptorelin with 0.2 or leupride 0.5 milligram. Luteal phase support, you have to add estrogen tablets along with progesterone and not to give HCG for luteal phase support. Or the last option is convert it into an IVF cycle with the antagonist. The next question is that in IUI you have given your trigger. So what is the best timing for insemination? If HCG is used, a single IUI can be done any time between 24 to 40 hours of the HCG without compromising pregnancy rates. And IUI in a natural cycle, that is not ovarian stimulated cycle, should be done 1 day after the LH rise. You can use the endogenous LH kits to detect the LH surge. And if it is with exogenous HCG, that is single IUI 36 to 38 hours later, and double IUI 24 and 48 hours after HCG. And just to mention, although I mentioned double IUI, but I am not doing double IUI commonly because as per ESHRE guideline, both unexplained and male infertility, there is insufficient evidence that double IUI can lead to a better pregnancy rate. Now you have given your trigger, but there is no ovulation. I mean, you have done your ultrasound and after 36 hours, then you waited for another day, still the dominant follicle didn't rupture. So what is the reason? Now follicular rupture is actually defined as decrease in the mean follicular diameter of at least 3 millimeters. And if you had used a larger, means remember the first slide, it is not an explosive event. So if you use a larger cutoff follicle, then maybe you have mistaken a ruptured follicle for an unruptured follicle because there is refill. Even after IVF, we see many times there's refill of follicles. So the correlation between the size of the follicle at the time of HCG and probability of rupture indicates that there is a threshold of biochemical maturity. The follicle has to reach a particular threshold before it is going to ovulate. So you must check, have you assessed ovulation correctly? Is this a partial or a complete LUF? Is the trigger given at the correct time of maturity of the follicles? Only half of all the follicles that you get by CC or HMG and HCG do rupture. This is really important because in an individual case, like today we were doing an IUI and the patient is asking how many follicles have ruptured, which follicles have ruptured. So we must know that usually it is only about half the follicles which rupture. And what are the etiological factors which are postulated for LUF? Mechanical obstruction by adhesion, very, very old studies, but this is still widely quoted today. Psychological stress, disturbed hormonal profile, for example, elevated prolactin concentration, defective ovulatory surge, maybe some external factors causing a problem with your ovulation inducing agent, or an abnormal FSH concentrations. So what are the measures that we can take to overcome or avoid LUF? Adequate ovarian stimulation, especially it is seen with HMG and HCG. LUF is very less. Correct follicular scanning, avoid stress condition, diagnose and treat endometriosis, pelvic adhesion, correct hyperprolactinemia. Don't give NSAIDs in the peri-ovulatory phase, and in recurrent, IVF is the option. Now coming to IVF. So in IVF, this first slide is about the natural cycle. And in a natural cycle, what happens is an LH surge goes together with the FSH surge. Why is this important? Because in HCG, we don't have an FSH surge, we have only an LH surge with a very long half-life. And what is the benefit of this FSH surge? It promotes the LH receptor formation in the luteinizing granulosa cells, promotes nuclear maturation and expansion of the cumulus. So we have this trial 21447, very large randomized double-blind trial was done, and what they found was that they compared implantation and pregnancy rates following with recombinant LH versus HCG, because all of us would think, if LH is so good, it will cause FSH and LH surge both, then why don't we use LH? Why are we using HCG? What is the logic? So this is the logic, that in order for recombinant human LH to be as effective as not only recombinant HCG but even urinary HCG, you have to increase the dose to a point where the trigger will cost 20, 30, 40,000 rupees. So it becomes totally adverse cost benefit ratio. And so this study was not even published. It was the European recombinant LH study group. Very high dose of almost 30,000 was found to be equivalent to 5,000 units of HCG. OHS is significantly reduced but increased cost, and highest efficacy between 15 to 30,000. So recombinant LH is absolutely not a viable option for trigger. Now with HCG, what is the other option? So HCG you can use in 3,500, 5,000, 10,000 international units, or GnRH agonist, that is triptorelin, is the GnRH agonist of choice, because I have used all three and beyond doubt the best results I have got are triptorelin 0.2 milligram, glucerolin 0.5 milligram is the other option, duprolide acetate 0.5 milligram is generally less. So if you're using it, use at least 1 milligram or 1.5 milligram. Sometimes you can use an agonist along with HCG. You can do dual trigger. It can be used in luteal phase rescue and of course kisspeptin. So the dose of HCG can also be titrated based on your estradiol levels. If estradiol is less than 1500, the dose can be 10,000 IU, between 1500 to 2500, 5000 IU, 2500 to 3000, 4000 IU, and about 3000 3,300. So it is being shown that even 2,500 units of HCG is sufficient to trigger ovulation. But we always tend to use little higher doses. Why? Because the complete nuclear and cytoplasmic maturation may not occur, even though ovulation may occur at 2,500 units. So this GnRH trigger is very highly suited. This is a bit of repetition of what has already been discussed, but In oocyte donors, to avoid ovarian hyperstimulation, GnRH agonist is perhaps the best suited trigger. In high responder patients, OHS is avoided, good oocyte quality, reduction in luteal. But the problem is that we don't know what is the best luteal phase support. In normo responders, again, OHS is avoided, fertility preservation. So this is the most common indication, this is an ideal indication for GnRH agonists where you want to avoid OHSs. Now, what about urinary versus recombinant HCG in the Cochrane study? So what is published is that there is absolutely no difference between the recombinant and the urinary HCG regarding the ongoing pregnancy rate and the live birth rate. What about GnRH agonist versus HCG? The Cochrane study. So what they have found is that again there is absolutely no difference, but the only problem that comes is in the luteal phase support. So if you give intensive luteal phase support, you can get equally good pregnancy rates. So with GnRH analog, this is a SWOT analysis. The strength is that is a physiological endogenous surge, but of course the problem is that the luteal phase is very poor, and it is an opportunity to develop individualized luteal phase support, like check the estrogen level. It has to be maintained more than 200, so you can give transdermal estradiol or you can give oral estradiol along with it. There are studies which have also said that more M2 oocytes can be collected, more physiological protocol of choice in oocyte donors, specifically for empty follicle syndrome. So if you have a patient who has immature oocyte, large proportion of immature oocytes, empty follicles, this probably is a suitable case for GnRH agonist trigger. And the only detrimental effect is luteal phase where the endometrial receptivity is reduced. So a word about dual trigger and double trigger. What is dual trigger? Dual trigger means giving a trigger with both GnRH agonist and HCG, because this will optimize the luteal phase and give best support to the pregnancy. Now, people also thought that what if we want to give a dual trigger versus a low dose, just if I can give a low dose HCG, which one is better? So if you give a dual trigger, which is in the form of 0.2 decapeptyl or 2 milligram lupron plus 1500 unit HCG versus just a low dose HCG, you will get a better mature oocyte rates with a dual trigger. So dual trigger is definitely more desirable if you are thinking of reducing your dose of HCG. Add a GnRH agonist that will boost your success rates. Now in poor responders, again, dual trigger final maturation, you get a higher proportion of M2 oocytes. Now, what about rescue? There is a concept that if you have empty follicle syndrome, can you rescue that cycle? So can you give another trigger and do egg collection again after 36 hours? I have done rescue cycles, and you can use this GnRH agonist. If you have already triggered with HCG, you have empty follicles, you have checked that the woman has taken HCG, you can stop the egg collection after one ovary, give a GnRH agonist trigger, and then do another. This is called as rescue HCG, and to treat the empty follicle syndrome. Now, this is different from double trigger. Double trigger means that GnRH analog is given 40 hours before and HCG is given 34 hours before. Again, these are modification for our difficult patient. We are seeing so many patients now with poor response. So this a patient who has recurrent empty follicle syndrome successfully treated by ovulation trigger of GnRH agonist 40 hours before and HCG 34 hours before, because it overcomes any subtle impairments in granulosa cell function, oocyte maturation. Now, again, this is a repetition of what we've discussed. FET cycles. Is there any role of trigger in FET cycles? So, if you are doing a natural cycle for frozen embryo transfer, then if you have a follicle that has developed, this is an RCT which looked at should you give HCG versus not giving HCG. And what they found was that no difference was found in clinical outcome between the protocols. So you make the treatment choice according to your preference. The advantage with this modified natural cycle FET, modified means you're giving an HCG trigger, is timing. So it is time, you have a team, you have staff, so you can time everything properly by giving a trigger in FET cycles. Also remember that there is the effect of body weight on HCG pharmacokinetics, where the bioavailability of HCG is lower in women with higher BMI. And last, a word about kisspeptin. I'm very proud to say I'm from Imperial College, 2 years of my research, and that is where kisspeptin was developed in London, and it signals direct to GnRH neurons to release GnRH agonists into the portal circulation. It stimulates the secretion of both LH and FSH from the gonadotropes of the anterior pituitary. And they were this was described by Abara et al. That they were able to effectively elicit an LH surge for final maturation. So the new trigger may offer a completely new natural pharmacological option, and the risk of OHSs may be eliminated. So just a final few points that whenever you have a patient, review the previous treatments, possibly if you can, so that you can tailor the approach before the treatment. Do counseling, differentiate your goals, whether it is ovulation induction, controlled ovarian stimulation, try and do your own ultrasounds. And now, of course, everybody has to tie up with an IVF center if you want to practice infertility. So thank you everybody for a very patient hearing, and Poonam ma'am, Shabda Jain ma'am for this wonderful opportunity. Yeah.
I'm not sure if sir is there. Sharma sir, then you can carry on.
Yeah. Excellent presentation by Dr. Shivani as usual, and she has covered all the angles of trigger, and yes, the newer product which she has mentioned, possibly that will revolutionize the way we do the trigger in the future. And the my only she had given a very nice slide where she showed the 14 hours of developing the LH levels and 14 hours of plateau and 14 hours this thing. Now see, when we give dual trigger, we are giving the agonist which is going to release the LH and FSH from the pituitary gland. So that will take about 12 hours, and we are giving HCG also at the same time, which is giving the LH immediately. So should we continue doing our pickups at 36 hours only, or we should delay it? Or one of the papers had shown that you give LH, this agonist, 40 hours before the pickup, and HCG at 36 hours. So I think should we now, instead of giving both together, shift to 40 hours of agonist and 36 hours of HCG trigger? Dr. Shivani.
No, sir. Actually, if your patient is a poor responder, you will be in, it is going to be very tricky, because if you give 40 hours before, and there is always a risk that in poor responders, there could be some premature luteinization, premature ovulation. So it is only specifically as a last resort in cases where previous treatments have failed that we can go ahead for this. That is what I feel, because there is so much data published on trigger. I thought it will be a small topic, but there are so many studies published on it.
Because it looks very logical, because whatever agonist we give it, finally it is going to act on the pituitary gland to release the LH, and it is going to take time. And while HCG will immediately give the LH, that surrogate LH. So this question, came to my mind. So
डॉक्टर टाइमिंग तो उतना ही रखना पड़ेगा, अगर अंडे ही खिसक गए तो क्या फायदा हुआ?
No, that's what I'm saying. We need to do some little research on that. How much time, giving agonist, the LH will be released, and how much time when we give HCG, the blood level will reach that optimum level, and then possibly then equilibrate. Because why I'm telling you this is because in PCO patients and all, we all are giving, say, suppose the dual trigger, and we find that many of the oocytes are in the M1 or GV stage. So is it because of that that we are not segregating the timings of both? We are giving both together because by the time actually only the SCG has worked. LH has not worked as yet because the agonist had to go to the pituitary and all this. This thought came to my mind.
And sir, even in a long protocol, probably you have a lot of margin, because the cycle is well controlled. But if you're doing antagonist protocol, I don't know if you have that much margin, especially in poor responders, that you maybe in cases like this empty follicle syndrome and nothing works, we can go ahead.
Dr. Shivani, I just want to ask, there are query in people's mind. And when people start asking, then I also have query in my mind. What is the right dose for trigger in IUI, in gonadotrophin cycle? And what is the dose of trigger in or oral ovulation plus gonadotrophins? And what is the dose of HCG in IVF cycles? People are confused thoroughly.
Ma'am, between 5 to 10,000 units, if you are using 10,000, the purpose is because you are also providing luteal phase support. Yes, ma'am, but if you are using 10,000, you are also providing luteal phase support for pregnancy because of the very long half-life of HCG. So if you are doing with that objective in mind, you could give 10,000. But of course, this says that even 3,000 units is enough to trigger ovulation. So even 5,000 units should be good. But the concept is of there is maybe a concept of luteal phase support also with the use of HCGs. Brigadier Sharma sir will be able to, I think.
As a policy matter, we give in IUI only 5,000 HCG, and in IVF we give 10,000. Brigadier Sharma, what is your opinion?
Yeah, actually, when I was in the initial stages of my career, so they used to say 5,000 is for ovulation and 5,000 is for the luteal support, provided you are not expecting the ovarian hyperstimulation. So in a IUI where you are just making 2 eggs or 3 eggs, so there possibly you can give 10,000. So it will also give the luteal support. So 5,000 for induction and for ovulation and 5,000 for the luteal phase support. So I think that still holds good. So in a IUI cycle, when we are giving trigger, we can, if the eggs are less in number, so we can give 10,000 IU. But in case the eggs are more, then definitely we should not give more than 5,000. If there are more than 3 eggs
I
or
think
so.
people want to hear it from you. Whenever you're using a clomiphene or letrose, trigger is not required. What do you have to say?
No. I think there is a subgroup of patients who would not ovulate and the cycle will go for a waste. So in case the patient has got so 2 or 3 eggs, definitely you should give trigger. But if the more eggs are there, so I'm expecting more E2 also. When E2 is more, I'm expecting the spontaneous LS surge also in those patients. So only when the number of eggs is more than 3, I can avoid giving SCG because I expect normal LS surge and I don't want patient to go to HSS in that patient. So, but if the number is 2 or 3, I think one should give a trigger to these patients.
Dr. Sunita Arora?
Sir, in progesterone prime cycle, any difference in the trigger, or we can give any trigger, especially if we are doing it for PCOS patient?
Yeah, you can give
Progesterone prime
SCG.
cycle, the trigger is they are giving NTAG or NTAG plus SCG. Both. I reviewed the literature. It is like this.
No, for IVF patients.
IVF है. Progesterone prime तो IVF की बात हो रही है.
Ma'am, progesterone prime PCOS में. Probably Dr. Jyoti is asking this questions.
Yeah, that's what I was asking.
Trigger is either they had their whatever studies I saw. They divided into 2 groups. They gave agonist trigger or agonist plus HCG.
Madam,
So it is good to give agonist and freeze.
Yeah.
Dr. Sunita Arora, she is from Bloom IVF Center.
Am I audible, Dr. Poonam?
Yes, perfectly.
So अभी मैम वो पूछ रहे थे, she was discussing around trigger in IUI ना. So ma'am, I also prefer a trigger always in an IUI cycle because the control becomes better. But one point which I usually make sure is, suppose patient gives me a history that she ruptures her follicle 24 hours after only, after the trigger in previous cycle, then I usually call the patients next day and check if the follicle is ruptured. Then I do IUI in that on that day only, 24 hours later, because sometimes patients they come up with this history ki jaldi rupture ho jata hai. But usually, as Dr. Brigadier Sharma sir said, to give trigger is something which I also prefer even in IUI cycles. And Shivani has really given a very nice presentation, and she's covered all the aspects so beautifully well. And I am also using dual trigger for poor responders and getting good results, in the sense that sometimes, you know, poor responders, when they say that some cycles happened outside egg, empty follicles mila. So dual trigger mein, I'm finding that most of the times we are getting, eggs per follicle as compared to when only one trigger is given. So dual trigger is
डुअल में
something
आप
which
क्या
I
यूज करते हैं? आप क्या यूज करते हैं?
Ma'am, I used 0.2 milligrams of this thing, triptorelin, with 500 micrograms of recombinant HCG. So most of the times I'm using recombinant HCG only, hardly using urinary HCG. But in IUI cycles, I use both, urinary also and recombinant also. एंड जो अभी शर्मा सर बोल रहे थे, सर जो 40 आवर्स वाला आप कह रहे हो, बट देन नाउ देर आर सो मेनी स्टडीज विच इवन से कि 35 आवर्स पे करो पिकअप, बिकॉज मेच्योरिटी थोड़ा सा बेटर होगी. सो 40 आवर्स, बिकॉज वंस इन अ वाइल कभी कभी लेट हो जाता है पिकअप आधा घंटा भी, एंड देन वी लूज एग. सो 40 आवर्स पे जाना तो थोड़ा सा ट्रिकी लग रहा है कि whether we should be waiting for 40 hours.
No,
So
no,
I
actually,
think,
Dr. Shivani had presented, shown one paper
yeah,
where they
Hanji,
had
Hanji,
given
Hanji.
agonist at 40 hours and then HCG at 36 hours.
Yeah,
So,
34 hours.
keeping that in mind, so that looked very logical to me, because
Yeah.
the agonist has to work on the pituitary to release a LH. So this is what I wanted to know. But
Sir,
yes, all
one
of
thing
us.
which I'm doing for my PCO patients is, sometimes again PCO also, they have a history that, there were so many empty follicles. So what I am seeing is, like, suppose it is a borderline PCO and E2 is just 2800, below 3000, but the follicle number is 15, 16. So if I have given an agonist trigger, then I'm calling them after 12 hours to do an LH. And if LH is less than 30, then I give them a dose of HCG. So this is something, which I'm finding. I don't know whether it is just psychological, but then number of eggs I'm getting is better. Although those patients are very few who have got just borderline HCG, and I'm little scared of giving them HCG directly, who have borderline E2, and I'm scared to give them HCG. So I give agonist only, but after 12 hours, I do an LH. And if I find LH is less, then I support it with a dose of HCG there.
How much?
And that dose 250 micrograms, not
Let's mean how
500
much
to
cutoff? How much cutoff?
if it is just touching your 3000 borderline level, like 2800 hai, but follicles aapko 15-16 nazar
And
aa rahe hain.
LH.
Less than 30,
Less
then
than
then I support it with HCG, a very small dose though. Sometimes even 1/3 of an Ovitrel I'm giving to PCO patients. That's again unofficial, but then probably it increases the number of mature eggs.
Can I add?
I just want to add a little tip which may be helpful to all of you. See, all these PCO patients, or we, or some patients, we expect that they are likely to have a premature ovulation before the pickup only. So what I do is that I give them the Brufen tablet on the day of the trigger onwards. So you give so that because how the rupture occurs, because the prostaglandins are released over there in the wall of the follicles, and that in turn causes changes intercellular walls. They become thinner, and the stretching of the intercellular wall takes place. That is how the follicle ruptures. The process, if you understand physiology. So at that level, if you give something antiprostate and NSAIDs and all, so that will prevent the spontaneous rupture to take place before you do the pickup. So from the trigger day and day prior to the pickup, we give it. And once a patient comes to the morning, because we normally call them 2 hours before the pickup. So that time, in case she's complaining of too much of pain, especially PCO patient, then we also, I think you all also must be adding paracetamol, so that we don't want to do the pickup early, because otherwise you may get more GVs and M1s. So that is the strategy, which I normally use it.
Dr. Aruna, you want to say something?
Actually, no comments. Dr. Shivani had made an excellent presentation. I would rather like to comment on one of the slides. We had been using SCG 10,000 for IUI randomly and maybe 5,000 for some patients. But Dr. Shivani's slide really, it has made a scientific approach to that. That SCG, depending on the E2 level, I really like that slide. And probably that clarifies everything, whatever we are doing and why we were doing, probably we didn't know, but now we know the reason.
So what I am using is I'm using 7,500. There is one company which is providing 75. I started using that.
But Dr. Shiva, with
So
Dr.
Dr.
Shivani's
Smita, you
slide,
want
all
to
of
say
us can
something?
streamline now.
Thank you. I think Dr. Smita wanted to say something.
I'm just calling her. Samita, आवाज बहुत कम आ रही बच्चे.
अच्छा एक मिनट जस्ट अ सेकंड हाँ मैं लैपटॉप पे थी ना तो शायद इसका माइक्रोफोन अभी सुनाई दे रहा है मैम
हाँ अब ठीक है.
हाँ सो जब आपने पूछा ना मैम आईयूआई और आईवीएफ में क्या डोज में डिफरेंस होना चाहिए शारदा मैम ने पूछा तो आई डोंट रिमेम्बर एग्जैक्टली बट मैंने एक बहुत अच्छे स्पीकर का लेक्चर सुना था एंड दे सेड कि 2000 जो डोज होती है दैट इज गुड इनफ टू रिज्यूम द meiotic division and this dose is sufficient for like if you're doing an IVF cycle but for a follicular rupture to happen you don't मतलब you need a higher dose so 5000 से कम तो IUI में चल ही नहीं सकता है एंड मोस्ट ऑफ द टाइम्स हमने बहुत बार देखा आईयूआई साइकिल्स में जब हम आईयूआई कर रहे होते हैं तब फॉलिकल रप्चर नहीं होता है तो ऐसे सेगमेंट ऑफ पेशेंट में मैंने डुअल ट्रिगर काफी बार यूज किया है आईयूआई साइकिल्स में 3 patients I have tried and follicular rupture हमेशा हुआ है and even in those जिसमें पहले मुझे नहीं मिला था although pregnancy एक में ही आई है with a good luteal support estrogen and progesterone so I am finding कि IUI cycles में भी dual trigger का अच्छा रोल है and HCG की डोज अगर आपके पास बहुत hyperstimulation का कोई रिस्क नहीं है तो I think 10,000 देने में भी कोई नुकसान नहीं है if you have 2 follicles
luteal support
from RK sir कि क्योंकि मेरे को याद नहीं आ रहा है कि किसने ये चीज बताई थी कि 2000 इज द मतलब आई हैव नॉट मैंने कोई लिटरेचर नहीं रीड किया बट जस्ट बाय talk I'm just
Dr. Megha.
तो 2000 भी
yes ma'am I comment on this that in some patients of my IUI when like first cycle patient is coming and egg is not ruptured with the HCG the rescue that luprate trigger I've tried and I've seen ruptures and very few have conceived. I don't have adequate numbers that I can I have tried in my patients.
Dr. Seema भी दिखे थे मुझे. Dr. Seema, are you there?
Yes, ma'am. I'm there. Same as
अब
with.
नहीं दिख रहे.
And we normally.
Hello.
Yeah. Dr. Poonam, Dr. Shivani, your talk was excellent, really, and it really clears us all the doubts and really make us aware of many things. And thing is, we are also using double trigger, and mostly we are using it because after SCG, we were like, if the dose is less than 5,000 or 5,000, we have to use it, this lupride again after 12 hours or after 24 hours. And as with you, Dr. Poonam, we are also using 2 version G0ur, that is 7,500 in all our IUI cycles.
7,500.
One more thing, I have a doubt.
So most of us are those who are using dual trigger. We are using it at the same time only. Now we are not using it at different times.
Yes.
And after 24, if the rupture is not there, then we are using lupride.
In IUI cycle, na?
IUI cycle.
I was talking of IVF cycles.
How many of you will justify a rescue dose because you have already given HCG and luteinization has happened. So even if you are giving
नहीं हो जाता स्मिता. We are patient. I remember.
एंडोमेट्रियम मिसमैच नहीं होगा, मतलब आपने ल्यूटिनाइजेशन तो 48 आवर्स मतलब ऑलमोस्ट इतना देर पहले हो चुका है, तो
नहीं, एग रिट्रीवल के लिए, दिस इज फॉर एग रिट्रीवल।
आईयूआई साइकिल में पूछ रही हूँ मैं, क्योंकि आईयूआई में मोस्टली मैंने देखा है लोगों को रिपीट ट्रिगर देते हुए, बट डज इट
आईयूआई में तो बहुत फ्लेक्सिबिलिटी है। यू स्टार्ट प्रोजेस्टेरॉन 3 days later 5 days, बहुत फ्लेक्सिबिलिटी है आईयूआई में तो।
नहीं प्रोजेस्टेरॉन नहीं, ट्रिगर की अगर मैं बात
हाँ, there is lot of flexibility. I mean, sir will of course guide us, but IUI में तो बहुत flexibility है। ऐसे this is a tremendously successful, ये जो rescue trigger होता है, it works for many people.
And after how many hours of rescue trigger do you do the IUI, Dr. Shivani?
Ma'am, 24 hours you check. And if not, then you know, जैसे मेरा तो usually around 38-40 hours तक I wait for the trigger.
So you all are first checking the rupture, then doing the IUI?
No, even
I'm
if
not
the
doing
rupture
like
is
that.
not there, IUI is
Yes,
done.
I'm also done. ठीक.
Shivani ma'am, thank you so much. It was very wonderful.
Sir, what is your protocol? You check first IUI and then do? Oh, sorry. You check first rupture and then do IUI? Hello, sir.
Oh, no, sorry. It was for me. Okay,
Yes,
I'm
sir.
so sorry. Yeah. The thing is, no, because you must do IUI, because if you wait for the rupture to see, okay, you done the ultrasound today and rupture has not taken place, you call her after, say, 24 hours next day. You must remember the fertilizability age of egg, oocyte is only 12 hours. While the sperms can survive for 48 hours in the female genitalia, the uterus, and in the tubes. So if you call her after, like she may rupture immediately after leaving your clinic, and you call after 24 hours. So already more than 12 hours of a fertilizability period is over. So it will not get fertilized. So one should allow them to, do the IUI for this patient, and at the same time, you allow them natural intercourse also. And if you want to confirm that this cycle the egg has ruptured or not, you can call them after 3 days or 4 days to confirm it, and then you can give the luteal support if you wish to give it. But remember, the egg remains fertilizable only for 12 hours. Okay, if the sperms do not reach the egg, or they reach at 14th hour or 15th hour, they will not, fertilize. Yeah.
I remember Dr. Rishikesh Pai used to say that why always eggs should wait? Why can't the sperm wait? Let the sperm wait.
But
मैडम here if in case of donor IUI cycles जहाँ पे आपके पास बैकअप प्लान नहीं है, where you are putting the washed semen sample, वहाँ पे तो the sperms are already like उनकी लाइफ कम होती है सर, शायद 2 to 3 hours सर्वाइव करते हैं वो.
क्यों?
No, it's not like that. No.
Why should it happen?
The sperms would survive whether you use the husband's sperm.
इंट्रायूट्राइन इंस्टिल किया है जैसे जो
नहीं, उसकी बॉडी को क्या पता ये हस्बैंड का स्पर्म आ रहा है या उसका आ रहा है? Why should it stay 2-3 hours?
रिप्रोडक्टिव ट्रैक में लाइफ क्या है जो आपने सिर्फ इंट्रा.
अच्छा, रिप्रोडक्टिव ट्रैक में 48 आवर्स तो है, इवन पीपल से 72 आवर्स भी है.
Sometimes even 7 days.
डेफिनेटली है, लेकिन इंट्रायूट्राइन एनवायरनमेंट में आई एम नॉट श्योर इफ समबडी कैन थ्रो अ लाइट ऑन दिस, बिकॉज़ जहाँ पे बैकअप आपके पास मेथड नहीं है इंटरकोर्स का, हाउ लॉन्ग इज द
I think 48 hours तो पक्का ही है, हमने रिजल्ट देखे ही हैं.
Dr. Jain, next time when you do the laparoscopy, do the examination and then take the fluid from the pouch of Douglas and see how many sperm do you find there. So that will be a good paper, for you to present it, because we all are growing old and you young population can do this, and it'll be a nice paper to know that how many hours the sperms can survive after maybe intercourse. You do the
Ask for Sumita now.
You time your laparoscopy, 48 hours or 24 hours after intercourse or 48 hours after the IUI, and see the difference, and let us also know.
Poonam ma'am, I have a doubt. Can I ask a question, ma'am?
Yes.
Ma'am, either Sharma sir or Shivani ma'am, whoever wants to answer, that if in, do you transfer it in when you give the dual trigger in IVF cycles? Do you transfer the same cycle, and what is the result when you give both Lupride and HCG?
Yes, we to do transfer.
Result is equally good, because some studies were initially that when you give the Lupride trigger, and you don't give HCG, like if you are not giving Ovitrail, if you're giving normal
People are
uterine.
working, we can't say about results because ना तो उसकी documentation है ना patients एक जैसे हैं, so it's very difficult to say कि आप नहीं करते तो होता कि नहीं होता, but generally it is going like that, and we are, you can do.
Giving Ovitrail trigger.
You can do.
Fresh transfer.
So
Okay.
is Dr. Shivani here? I just wanted to know the rescue trigger for an IVF cycle. The next OPU is planned after 24 hours or 36 hours? Anybody
34
can
hours उनकी slide में था.
24.
It was 34 hours in her slide.
Again after 34 hours?
Yeah.
Okay.
Sir,
So I think we conclude the session. Now, you want to say something?
I wanted to ask sir a question, sir. In one of the presentations, you told that like a lot of patients are getting resistant to HMG now. So you are using recombinant LH and all. So is that same true with the SCG as well?
Yes, yes. Because the urinary products, they may have, they always have some contamination, even if they are highly purified. And if the patient has got a history of repeated gonadotrophins or SCG previously, in those patients and previous IVF failure also in some of the cycle, then in this group, you preferably switch over to recombinant. So you will possibly require lesser dose and you get a better response to these patients.
So, sir, are there studies or is your experience?
No, there are studies to that effect also.
Okay.
That urinary products, the patient may become resistant, to the gonadotrophin because of the contaminated proteins which are present in the urinary products.
Okay, sir. Thank you, sir. Thank you.
So I think we are good
Especially
enough
in
now
India,
to
we will
conclude
see
the
that
session.
everywhere.
Poonam ma'am, sir को बुलाओ ना, Dr. Nair. Dr. Nair is there.
Dr. Nair, so मैंने बोला था, है sir. Dr. Nair, are you there? No, sir is not there.
No, I'm here.
Poonam madam,
Okay, sir. Please, your comments. I asked you first time, so I thought you have left.
सर को देखा ना इसलिए ऐसा क्या?
अच्छा.
Discussion.
जस्ट एक चीज मतलब जैसे डबल ट्रिगर के बाद लोगों ने कहा ना कि वो फ्रेश ट्रांसफर करते हैं या इवन आईयूआई की बात करें तो इसमें क्या एचसीजी को दोबारा देना चाहिए 1 वीक लेटर, बिकॉज जो एचसीजी आप देते हैं साथ में वो यूजुअली 1 वीक तक सस्टेन करता है कॉर्पस ल्यूटियम को, approximately 7 to 10 days. So apart from estrogen and progesterone, can we add a rescue dose of HCG on 10th day probably?
You see, once you are giving dual trigger, that is, you are giving either Lupride or Triptyline plus SCG. And if we are giving SCG 250 microgram of recombinant or even 5,000 or 2,000 IU of urinary, this SCG is going to last for at least 6 to 7 days, this effect. And by the time the implantation happens there, the embryo itself start producing progesterone. So we recently had Dr. Robert Fisher in Delhi, and he was saying that he is giving small dose of SCG after agonist trigger. You give an agonist trigger and follow it up with 100 IU or 125 IU of SCG every day for next 8 to 9 days only. Because after 9 days, the embryo itself will start producing progesterone. So there is no problem. You can always go ahead and do the fresh embryo transfer in the same cycle. But only thing is, we are giving IUI, you give dual trigger, you have to give a good luteal phase support. You have to give both estrogen and progesterone.
Yeah. And if the risk of OHSS is not much, I can even give an HCG dose 7th day.
Well, you can give, because that is what I'm trying to tell you. Generally, if the embryo has implanted, by 8 or 9 days, the embryo itself will start producing progesterone. And he said, it was very eye-opener talk he gave. He said, once you give 100 IU per day for 8 to 9 days, Thereafter, you don't give any progesterone support in the luteal phase. No, nothing. It is the pregnancy itself is producing progesterone. There is no need to add from outside. There is no need to add from outside. It can just support itself.
Okay, sir. Thank you so much.
Thank you, sir.
Thank you,
Thank
ma'am.
you, sir. I think Madam has left, so I think we can conclude now. I thank Dr. K.D. Nair, sir, Dr. Sharma, sir, and all my esteemed faculty and my delegates who have joined. Thank you so much.
Thank you, ma'am.
We'll
Thank
be
you.
meeting again on 20th next month, 4 p.m.
Thank you, ma'am.
Sure.
Thank you.
Thank you, ma'am. Thank you so much.
Thank you.